Who performed the diagnosis of brain death? Any trained physician except the surgeon or transplant physician, or the ICU nurse, or the transplant surgeons, or only by intensivist or neurologist? In your view, who performed the diagnosis of brain death? Interesting. The majority give the number 4 only by intensivist and neurologist. And we believe the number 1 is the right answer, that any trained physician, except who are involved in transplantation, can perform the diagnosis of brain death. Next. The apnea test should be done as first test, or it is an optional, or last test to be performed, or should be done twice in order to make brain death declaration. So the apnea test. Okay, 47% give that as last test to be performed, and good number, but about 30% believe it should be done twice. Okay. Next. The absolute contraindication for organ donation is primary brain tumor, or head injury secondary to gunshot, or secondary tumor. What are the absolute contraindications for organ donation? Okay. Secondary tumor, of course, this is an absolute contraindication for donation, 75%. Very good. Next. Switching of ventilator after brain death declaration should never be done, or it is upon doctor's decision, or it is a family matter, or there is fatwa to be considered. In your view, what is the most appropriate answer for switching of ventilator after brain death declaration? Okay. Interesting. Should never be done, 19%, 33% upon doctor decision. A family matter believe 11%. It is really dilemma and big issue, always under dilemma between doctors, nurses, and ethics. But we believe it is upon doctor decision based on the clear fatwa to be considered. Next. Can a 65 years old person donate his organ? Yes or no? Okay. Good. The majority give yes, that nowadays we are using more and more marginal and extended criteria donor. Yes, can be considered for organ donation. Next. Can a 30 years old person donate a kidney to a child who is 5 years old? Yes or no? Very good. Majority believe it's yes, right answer. Next. When brain death occurs, the blood circulation to the brain continues. It's right, yes or no? Still blood flow to the brain or no? (50-50), wow. Okay, very interesting. 56% say the right answer, no, but still 44% believe the circulation still remain in the brain. Next. As a precondition for diagnosing brain death, the body temperature should be less than 34 degrees centigrade, or greater or equal 35.5 degrees centigrade, or above 36.5 degrees centigrade. This is, we put this question based on our national protocol used in Saudi Arabia and GCC countries as precondition to diagnose brain death. Okay. The majority believe greater or equal 35.5. In fact, the national protocol was modified last year, and a new protocol came out and adopted, and also in all GCC countries, that as precondition is enough to have the at least 34 degrees centigrade. Next. The most common cause of brain death in deceased donor is drug abuse, or primary brain tumor, or road traffic accident, motor vehicle accident, or cerebrovascular accident. Okay. The majority give as road traffic accident. Of course, in the Western country, more and more they are dealing with the cerebrovascular accident. And even in Saudi Arabia, the picture has changed. And nowadays, 50-50. We are dealing only 50% as road traffic accident for a cause of brain death. Next. The brain death declaration of a deceased donor should be signed after harvesting, yes or no, to declare brain death. %36% believed yes, should be done after harvesting. I don't know any surgeon could accept this as transplantation, working in the field transplantation. Of course, the right answer that no. Okay, next. Previous cardiac arrest in a potential donor always make him unsuitable donor, yes or no? If cardiac arrest happened in the ICU and successful resuscitation done, still we can consider him as suitable or no? Majority believe no. Okay, very good. We'll explain more on the evaluation and of deceased donor.
The other place is now ready.
Very good. Okay. So we open the other room. Will be live transmission. The same slides and sound is available in the next room. In case they have more and more attendees, I'd like to attend this one. Okay. Viable organ from deceased donation can be performed after keeping the cadaver in the mortuary, or can be retrieved without family consent, or can be performed without clinical examination, or can be performed in a non-heart beating donor. In your view, what is the most appropriate answer in these four scenarios when we are considering organ from deceased donation? Okay. Very good. So can be performed in a non-heart beating donor. This is the most appropriate answer with 58, 59%. Very good. Next. Accepting the concept of organ donation is based on, is a part of your job as medical practitioner, or because of religious scholar agreed upon?
There is a translator to Arabic for anybody who is interested.
Sure. Yes, all lectures are translated into Arabic, and you have mic and to use it, earphone, to use to listen to all talks in Arabic, and even if you want to interact, your question could be done in Arabic or English. So accepting the concept of organ donation is based on the part of your job as medical practitioner, or because of religious scholar agreed upon, or because of the number of patients in organ failure are increasing, or all the above. Okay, very nice. 91% give that all the above. For all these reasons, we are accepting to deal with the organ donation, especially from deceased donor. Next, deceased organ donation in Saudi Arabia is agreed upon by previously signed donor card, or consent from next of kin, or family consent is not mandatory, or it's not allowed in Saudi Arabia. Wow, okay. So 34% believe that previously signed donor card. Here we are following the opting-in system that donation, the consent from next of kin is obligatory. So we have to get consent. The best way to express your wish for organ donation after death is to hold a signed donor card, or to inform your family about your wish to donate, or to get a medical report from your treating physician, or 1 and 2, that mean to hold a donor card and to inform your family. Okay, 1 and 2, the majority. This is the right choice, that to inform your family and to hold a signed donor card. Next. Your position toward organ donation is based upon, are you objecting for religious reason, or are you objecting for social reason, or you accept the concept of organ donation, or you still need more information. So please feel free to put the appropriate answer for you. Very good. Majority accepts, but still 24% need more information about the organ donation. Okay, next. Your position towards organ donation program. Are you against it, or are you supporting the program, or neither nor? Very good. Majority support our program. So our task today is really not so difficult. The last question? No, this was the last question. Thank you very much. Thank you.
Okay, assalamu alaikum. Welcome everybody. Before we proceed for our next program, the idea was for this question is just to check in your pre-knowledge. Later on we will try to do it again to see your final knowledge about it, not to test your knowledge, because it is, well, before we proceed for our program, we warm welcome to our guest, Fitzgerald and Dr. Robert. Very welcome to Riyadh and welcome to our pre-congress. And I warmly welcome my first director, Dr. Saleh from he's the first director of Saudi Center for Organ Transplantation when it was National Kidney Foundation. So warmly welcome Dr. Saleh to our program, and to Congress, and to Riyadh. Welcome Dr. Robert and Fitzgerald. You are very welcome. Feel happy and enjoy your time with us and in the Congress and in Riyadh. So we'll proceed for our lectures, and please, kindly, the mic is there. Feel free to ask questions. We learn from you. When you ask us, we don't learn. We are not giving lectures. You are consultants, anesthesiologists. You know that, you know it. But we are discussing issues here, organ process, procurement. So feel free to ask questions at any time. Don't hesitate. Our next speaker is going to be Dr. Mohammed Ziad Suqiya. Dr. Mohammed Ziad Suqiya is a consultant nephrologist, and he is the director of the in the scope of the Bulletin, our magazine, and in the research center in Scott. Welcome. He's going to talk about the critical pathway on organ donation. Welcome, Doctor.
Good morning, everybody. The process of organ donation and procurement of organs is a logical process. Starts with identification of the donors, and then proceed with confirmation of their death, and then request for consent, and then utilize the organs after retrieval. Since the transplantation community worldwide is interested in this process, they met on an international level to put a certain language which they can communicate through. And as you can see here from the logos, that the World Health Organization is interested in it, the Transplantation Society, and other organ procurement networks. So they decided to have a steering committee to put such language, for the process, in order to speak the same words all over the world. So they started from Sydney, then, as you can see the timeline, from 2008 till 2010, and several, locations, including Geneva, Berlin, and then Madrid. And, experts like these, attended those meetings, and to believe that, you have the list here of the organizations and the countries involved, in the process. And then they came up with this, chart for with cascade for possible diseased organ donation. They said that if we want to consider an organ donor, it should be mechanically ventilated with devastating brain injury or lesion, and apparently medically suitable for organ donation. And they divided them into two groups. The first group is the donation after brain death. The treating physician should identify the donor's potential donor, then appears on the list instead of possible on the top. Then the eligible then becomes actual donor, and then we utilize the organ donation. The other group is donation after circulatory death, and it seems that they decided that they have the same pathway for potential, eligible, actual, and utilized. And then they have how to identify those donors. This chart was published, and if anybody wants to review them, so we printed them on the stands here. But I'm going, after I finish this slide, to go step by step to identify you with the content of this chart. And this is my job in the next 10 minutes. And then we'll proceed to the next. The identification and referral, we have it's an essential step which informs the organ procurement organization, organ donation personnel of an individual that could be possible or potential or eligible for organ donation. This is what we call identification and referral, like what we do for Scott. People call in, or we call them and get the possible donors, and then we proceed from there. When should referral occur? For the donors of brain death, they say at minimum, when the donor is eligible, and for the death by circulatory cessation is when we have a potential donor. So we have terms which are confusing. So we have to identify each one and learn them. Why? Because you are going to hear about them all day long today, at least. And for both, it is preferable when they are in the possible stage. Or, referral may occur when the family requests to speak to the organ procurement personnel or officers. Let's go to the cascade of the death by of brain death. We have the possible donors. We mean that mechanically ventilated with a brain lesion apparently medically suitable. So if somebody is not on ventilator, you don't consider such person a possible donor because he's still alive. And you try to move such possible donor into a potential donor by suspecting and fulfill brain death criteria. So you have a protocol. You are going to hear about it. More detail in the following speakers, so you'll have better idea about the details of such protocol. In this stage, a patient may recover or may fail to identify him as a donor, or patient has unanticipated cardiac arrest and dies. Then we try to move the potential donor into an eligible donor. And by finding that he's medically suitable and declared dead. So we have to fulfill the protocol. At the same time, we try to find that the body has no other contraindication for donation, like somebody who has cancer, for example, is maybe brain dead and declared dead, but he's not medically suitable to donate. Here at this stage, we also may fail to identify or refer. The brain death diagnosis could not be confirmed or completed for technical reasons, or potential donor not medically suitable, or hemodynamically unstable. We try to move after that the eligible and confirmed brain dead person who is suitable into an actual donor by getting a consent from family, and at least one organ can be recovered from such donor, not necessary to be multi-organ donor. What happens at this stage? We may also fail to refer, even at this late stage, to inform the organ procurement organization that we have a donor and what to do, or possible donor, then actual potential eligible and actual. We may even fail at this stage, to cooperate. The hemodynamically unstable that leads to cardiac arrest may happen. Expression intent of disease not to be a donor. That's happened during life. We discovered that because the disease cannot express the opinion at this stage. Only family or previously declared as such. Relatives refusal permission to organ donation may happen at this stage. Refusal by coroner or other judicial officer, logistic problems, no recovery team. Sometimes you don't have surgeons to harvest organs, lack of appropriate recipient. And all happen practically in everyday life situation. After that, the utilized donors, these who have one organ transplanted, also at this stage, anatomic, physiological, functional abnormalities of organs may happen, and organ damage during recovery, inadequate perfusion may happen, logistic problems to perform transportation may happen, lack of appropriate recipient may happen. So you can see that it is not an easy job for anybody who is handling such cases, so it needs complete cooperation between the attending physician and the intensive care where the patient is ventilated, and also the organ procurement organization and its staff. We have similar waterfall or cascade for those with death by cessation of circulation. The same thing, if you look, I'm going to run them quickly because we run them slowly. And here we consider something, the same cascade, but the problems may be a little bit different. The same thing, you see. So, since the chart does not differentiate very much between those who have cardiac arrest before the donation or after, makes the cascade even simpler in mind about those categories. Now, have we been practicing this in Saudi Arabia? If we look at the categories possible, the potential, the eligible, actual, utilized, we find that in Saudi system we have instead of possible, we used to call them reported. And from my description, you could see that possible, you have to try to report early. That means we consider the ventilated person with severe brain damage to the organ procurement organization. The second one, the potential, we said this is the stage of documentation. We used to call it here documented. The eligible, we used to call it consented. The same, so we are changing the terms a little bit, but not the process. The process remains the same. You suspect, you identify, you try to confirm, report time, from early stage, and you follow through, till you harvest, which is the actual one. And you can see, against each one, the definition, and then you utilized, which we have the same term in Saudi Arabia. You can see here our 2010 statistics. We have the reported, 615 cases were reported during 2010. And the estimated ratio per million population is 23 per million population. We are going to discuss the comparison with other systems and other countries later on during the day. So you'll hear more about these statistics. from them, we have a smaller fraction of documented, or we call them potential from now on, and we have 14 per million population, and also a smaller fraction when we get consent, which is eligible, and we have the harvesting, which is the actual 4 per million population, drop from 23 per million population to those who are actual donors, and we utilize most of them, luckily, because we have a system of checking every detail about their medical status besides the documentation of brain death. My conclusion is that the universal language of terms used in deceased organ donation is a useful tool for registries and research, so scientists can speak the same language, and when you find a report, you can say that, oh yes, I can compare this one with another report from another place. Second point is that the international efforts to unify terms used in the process of diseased organ donation reflect the desire of the organ donation community to mutual understanding and work together to achieve better performance in this field worldwide. And this is the example of it. Thank you very much.
Thank you very much. Thank you very much, Doctor. Professor Major. I don't know. Introduce Dr. Bar. He's here. Okay. Any question for Dr. Ziad? No, the pathway we meant about it, what is the new, like possible, critical. You used to say a potential brain death. We are no more telling potential. If there's an actual potential or possible. These are the terms which was given. Any question from the audience? Okay, thank you very much, Dr. Ziad Suqi, for your lecture. And I think we are supposed to have Dr. Faisal the coming lecture, and since he is not here, warm welcome to our distinguished guest, Dr. Muhammad Al-Bar. It seems to be we will not let you complete your tea, or bring it with you. You're welcome. Kindly welcome Dr. Muhammad Al-Bar. Yes.
Where is it?
Okay, Dr. Muhammad Al-Bar is a consultant in Islamic medicine. He is a physician working in Jeddah. He is one of the below of this restrictions of the Brain Death Committee. Had been with us for the last 25 years, working in the Brain Death Committee, constricting the issue, putting the law, and changing things according to our situation in the country here in Saudi Arabia. And had been flying with us through all the country, giving lecture, giving the most important issue of the Islamic and the Fatwa, an explanation of the Fatwa. That's why I wanted really his talk to be a sort of a debatable discussion, because there are few things in Islamic points need to be clarified and need to be very clear to us all. Still, in some issues, there is a big question mark. Still, in some issues, there is yes or no. Some issues we agree and disagree. We are here to know which is. Welcome, Dr. Muhammad.
Bismillah ar-Rahman ar-Rahim. I'll talk on the Islamic point of view on very difficult questions of brain death and organ transplantation. ايش هذا؟ ما يمشي. ما عملنا نرجع. لا ما جاب الانجليزي هو. How you get back? ايه ما جاب الانجليزي.
تطلع منها؟ تطلع منه كله؟
ما هو كان اسهل هذا صعبه. لا لسه. هو في نفسه هو نفسه. انجليزي وعربي هو نفسه. ايه. طيب. How to get forward? How to get forward? Yeah, that's okay. Yeah. No. رجعها لورا. Okay. It is here. I'm asking here. That's it. Easy. Yeah. That's easy. This. Okay. Sorry for this delay. The computer. The question of the value of the human being in Islam, and from that point of view comes the ethos, the philosophy of either acceptance or rejection of difficult questions of brain death and organ transplantation. Now, okay. In the Quran, there is the human being. We have honored the progeny of Adam, provided them with transplanted land, and so on. And the human being is the vigilant of God himself on this earth. So it has a very important value. And that them. And it's not only the children of Israel, it's the children of Adam, the whole human, which makes a bit of difference here. And it is not only when he's living that he should be respected and venerated, but even when he's dead. And this is exemplified by at the time of the Prophet, there was a fight between the Jews and Muslims, and they tried to assassinate the Prophet several times. But when the funeral of a Jew was passing by, he stood in veneration, in respect for the passing by funeral. And one of the companions of the Prophet exclaimed, "Is it not a human?" He said, "It is only a funeral of a Jew." And he said, "That's his of our enemies." And he said, "Is it not a human soul? To be respected, whether he is your enemy or your friend." And that's a very important philosophy that we have. Now, other point there, which our jurists took for that time, when the Prophet entered the cemetery, he found somebody breaking the bones without any need for that at all. He's just breaking the bones of a dead person. And the Prophet was furious, and he said, breaking the bones of a dead is equal in guilt to the breaking of the bones of the living. So the same sin, the same guilt there. Now, from that point of view, many of our jurists at that time were thinking that taking an organ or opening the abdomen for venesection, for anatomy, studying anatomy or something of that sort, would be tantamount to mutilation. And mutilation is not allowed in Islam. Even with a rabid dog, you are not allowed to do mutilation. So some of the jurists at one time thought of this as a type of mutilation. But the answer was very quick from the also great learned people, from Imam Shafi'i, who lived about 1,300 years ago. And he said, look, knowledge is two branches, two main branches. One of religion, and the other one is medicine. And you cannot learn medicine unless you know the anatomy and physiology. At that time, what they called tashrih was involving both anatomy and physiology. So they allowed doing anatomy. And these are the reasons for to know study the body, and to also to know the diseases, autopsy and necropsy, and for forensic medicine in cases of doubt. And also they thought that if you know the body, you see the wonders of the creation, and you adore your God more than the usual thing. And up to a recent time, from Makkah al-Mukarramah here, 1987, 86, they were saying postmortems and autopsy were not allowed except for coroner's cases, that's medical legal, and for the diagnosis of difficult cases, and for the purpose of teaching anatomy and pathology. So it is allowed. Now, so the sacredness of the body, the sanctity of the body has been broken down here. It has been allowed to do for a good purpose. So for a good purpose, the sanctity of the human body is no longer valid. If you are going to do postmortems to study medicine, because you are saving lives, many lives for that reason. Now the other question becomes there, what is death? Death in all the cultures, up to this moment, I think, is the departure of the soul out of the body. But the soul is something and what is the signs of the departure of the soul? And the major signs were, of course, stopping respiration and stopping of circulation. So we came with in the 19th century about the cardiac death, with stethoscopes coming up, and then lately, in the 20th century, 1950, 59, they started to speak about coma de passé, the French, and then we had the notion of brain death in 1968 and so on. It went on from Harvard and so on, as you know. The brain death, there was a question of whole brain death, brainstem death, or cerebral death. Is a child of anencephaly born, is he considered dead? Some of these children will continue, very rare, but they continue for months since the brainstem is still working. And there are also the problem of persistent vegetative states, where the insult involves the cerebral hemispheres, but the brainstem is still working. So we have to get the notion that brainstem is very important, but our criteria involves the whole brain. And these are of the signs Prophet gave us, that the sight of the dying follows his soul as it departs. There is some of the dying people have some deviation of the eyeballs, and that person may be dying, but is not dead as yet. So these are one of the signs. Apnea test is very important. There's no respiration at all. And the second one, the cold calorie test, where there's no movement of the eyeballs when you instill the cold water into the ears. So there's no movement at all. That's another sign. Okay. Now we have a very high incidence of traffic accidents, and It's in Saudi Arabia about 8,000 per annum, which is very high with our population of 23 or 24 million. Those who arrive to the hospital already dead are more than 4,000, and those who die within 1 month, as the WHO signifies this, are another 4,000. So this is the brainstem death if there is any hemorrhage. And of course, hanging is another case of brainstem. This is a nice slide where the chicken head was chopped, but the chicken was standing for a long time. And that's a vexing question. Is this chicken was alive or dead? And I don't know. Any of the audience would suggest whether this is alive? Raise his hands, those who think it is alive. Not you. You're not included. It seems nobody thinks that it is dead. But it is actually alive, and it's remained there for months, being fed by a dropper because the chopping was above the brain stem. And I use this slide with our clergy, with our ulama, with our jurists, to make them understand the question of brain death. That brain death, because so many people are speaking about brain death, that when the brain is injured, they call brain death. Definitely, when you get your injury of brain, you get some. But the important issue is that the brainstem is still working. And if the brainstem is still working, that person or that animal is still living. So this is a very important issue. And when they understand this question, their animosity to the question of brain death becomes ameliorated, becomes much less, and they can track this question and understand it. Now, this is another child. It's called hydranencephaly. And you see, the whole brain is water. It's full of water. And there's also the black thing there. The black thing there is the brain stem, with a little bit of thalamus and hypothalamus and all these areas. And this also gives, if the whole brain goes while the brainstem is still functioning, that person is living. You cannot kill that person and take the organs from him, saying that he is already without brain. You see the point? The point is very important, practically and to the public and to the jurists, to understand this very vexing question. What do you mean by brain death? This brain is not there, but still there is a brain stem working, and that person by all means is living. You cannot take the organs from such a person. You cannot give him the label, he is brain death, and now we are going to take the heart, the liver, the kidney, and so on. That's not applicable. Now, this is another question which I said about. This is called anencephaly. Anencephaly is a Latin word or Greek word, which means without brain. But it's not true. There's still parts of the brain there. And some of these children continue to live. Usually they die within 24 or 33 hours, 3 days. Usually they die within 3 days. But some of them lived for 6 months and has been recorded. So you cannot consider this anencephalic as a dead person without brain, and you jump to take organs. It happened here in Jeddah, in Saudi Arabia, and they took 4 of these children that happened there, and they took the kidneys and they transplanted them to children. But then we had a fatwa from our jurists saying, no, wait, until either the heart stops or the brain death criteria is there, as you have prescribed it, with the death of the brain stem, then you can take the organs. But not prior to that. You have to be sure that the brain stem is not functioning anymore. So this is very important. This is Karen Quillen, probably well known because she's in 1970 something. She had a binge alcohol plus Valium. She knocked her circulation to the brain, but the brainstem was still functioning. She was on the ventilator, and she was well known because she went to the courts. The parents said, no, stop the ventilator, and then they got the court agreeing to it, and they stopped the ventilator, but she's lived for 10 years. After stopping the ventilator, only needing it from time to time, because the brainstem is still functioning. And nowadays, every hospital, almost in every country, a very big hospital, I mean, is having a lot of these persistent vegetative states who live for 10 years or 20 years. There are more than 20 years now recorded. They are living there. You cannot consider them dead, and you cannot jump to take their organs. That's impossible, because still they are living, because they have a brainstem still functioning. So this is a very important question. Now, we had a meeting with the International Islamic Journal. The meeting 6. They said it is legally and religiously considered that a person had died, and henceforth all the rules regarding a dead person as considered in Sharia are to be imposed if the heart and respiration stop completely irreversibly, and 2, if all the functions of the brain, all functions of the brain have been totally and irreversibly lost. And the specialist doctors have decided that this loss of function is total and irreversible, and that the brain of such a person had already started to show autolysis. In such a condition, it is allowed to remove the resuscitative measures, including the ventilators hooked to such a person, even though some organs like the heart may be still pumping blood as a result of the work of the machine. Now that was in Amman, 1986, and by November 1986, in the military hospital, we had the first brain death organ transplantation. It was very quick to grasp on this fatwa, very quick to grasp on this fatwa, and the fatwa was evident, allowing organ transplantation, and from that time on, Saudi Arabia is the leading country in doing organ transplantation from cadavers, from non-heart, from heart-beating cadavers, or whatever you might call them nowadays. They are changing the nominations. But that was the first cases of brain death cases that were utilized to take organs from them. It was followed by Kuwait and other countries later on. So, but it is not yet accepted in many Islamic countries, even in Egypt. And still in Iran, they don't accept it, and so many. In the States, they say an individual who has sustained either irreversible cessation of circulation and respiratory functions, or irreversible cessation of all the functions of the entire brain, including the brain stem, is dead. And that was about the same time that the fatwa came from Amman. That was the time of Mr. Reagan, President Reagan at that time. And our leaders never knew about this that's occurring at the same time without our knowledge what's happening there. Now, we will come to another question, which is important to doctors most of the time. If a person is on life support measures, but it was proved that his brain has stopped, and that was in 1983, before the fatwa, the international fatwa has been talking to you, and this fatwa came from Riyadh, from the Supreme Council of Ulama, research of fatwas, Bin Baz, rahmatullah alayh. Has stopped functioning irreversibly. Is it permissible to remove life-supporting machines? And the fatwa says it is permissible to stop the life support machines as he is considered dead. The movement of the heart and respiration are only through the machines working on a life. But it is imperative in his death wait a little bit until the heart stops and respiration stops completely. And that definitely will occur. Equipment could be lifted from the patient whose brain functions have completely and irreversibly stopped and has been decided by, even though the heart and respiration are still functioning. This is the same. Yeah, this is that was another fatwa from Saudi Arabia also. Arrives to the hospital already dead. There is no need for any resuscitative measure. If the medical file of the patient is already stamped, do not resuscitate according to the patient's will or his proxy, unsuitable. If three competent specialized physicians agree that he is unsuitable for resuscitation, then there is no need for such a measure. If decided that it is appropriate to resuscitate a patient who is suffering from a serious irremediable disease and that his death is almost certain or imminent, if the disease is irremediable and his death is almost certain, as witnessed by competent physicians, there is no need to use resuscitative measures. If the patient is mentally or physically incapacitated and is also suffering from stroke or late-stage cancer and so on, or having severe cardiopulmonary disease, if the condition of the patient is as prescribed and decision not to resuscitate has been reached by three competent physicians, then it is permissible not to resuscitate. Now, if the patient is it permissible not to resuscitate even though the patient or his relatives are there is no need for resuscitative measures to be carried. The opinion of the patient or his relative should not be, as it is a medical decision and it is not in their capacity to reach such a decision. However, consent to do not resuscitate. Trouble. So but when they get the fatwa from the most supreme sheikh, who was Sheikh bin Baz, then they use, as you have seen, brain death goes up and down. It is now about 600, but non-Saudis almost more than 50% are non-Saudis. I'm going. Total of transplantation, as you have seen, it is going up from 1 year to year, and you had the recent figures of 210. But organ transplantation is subject. Orthotopic autografts from Bronze Age, ancient ear construction, and the time of the Prophet, Battle of Kolab, he replaced it with silver nose, and the Prophet advised him to replace it with golden nose. Golden ornaments were not accepted for Long time ago.
Thank you. Okay now?
So, any sound? Okay. Huh? Can you hear me? Okay. Bone, auto, and xenografts from animals, were practiced by Muslim physicians and Muslim jurists allowing it. And that's Imam Nawawi sanctioned such procedures. That was about early in the 13th century. And this is from Mughal India, but Ibn Sina before that has written in his book of Al-Qanun, allowing, he said that the bone grafts, bone grafts, have been used at his time, but it was a dangerous operation that he will never do. It was very dangerous at that time, certainly. Infection and all the problems with it, and how they were doing it. This from Mughal India, Muslims India, were doing a nice organ transplantation. And we have fatwas allowing organ transplantation from in the 1959, allowing blood transfusion, corneal transplantation, 1966 allowing organ transplantation, and so on. It goes on. And in 1972 from Algeria, Sheikh Khater back from Egypt, harvesting skin from unidentified corpses. Saudi started here, sanctioned corneal transplants, allowing them. 79, Jad al-Haq back to Egypt, sanctioned live and cadaveric donation. Kuwaiti Fatwa sanctioned organ transplantation and opt-in system for cadavers. And Saudi Grand Ulama allowed organ transplantation. 1985, Islamic World League. 1986, brain death, as I've explained. And the 4th International Conference of Islamic Jurists allowed organ transplantation and proscribed commercialism and organ trafficking. And the 6th, 1990, they discussed transplantation from embryos, IVF projects, nervous system, and anencephalus. And the conditions for harvesting organs from the cadaver, consent of the deceased during his lifetime, or the consent of the relatives, or a consent from the magistrate for unknown cases. Is that okay? We're taking the time. Was not working?
Yeah, it's working now.
Was not working before?
No, battery problem.
Okay. Okay, don't worry.
Okay, sir.
Okay. And for a living should be a measure. And there are differences between places from one place to another. In Kuwait, they say 21. In other places, 18. And they never settled who is the measure exactly. But most of the countries are taking 18 as the measure. And no harm or minimal increased risk, and the necessity to save a life or something of that sort. The human body is the property of Allah. A man is entrusted with his body as well with his wealth. He should use it in the proper way. Now, there is a fatwa on stem cells which came 2003. Now, this is important. It is permissible to obtain stem cells to be grown and used for therapy or for permissible scientific research if its source is legitimate, as for example, adults. Sorry, I'm finishing. Adults, if they give permission without inflicting harm on them. To children, provided their guardian allow it for a legal benefit and without inflicting harm. The placenta or umbilical cord with the parents' permission. A fetus, if spontaneously aborted or when aborted for a therapeutic reason permitted by Sharia, by Islamic law, with the with the parents' permission, leftover zygotes remaining from in vitro fertilization if donated by the parents when it is ascertained that they will not be used in an illegal pregnancy. Second, it is forbidden to use stem cells if their source is illegal. For example, intentionally aborted fetuses, intentional fertilization between a donated ovum and the sperm, and therapeutic human cloning. I think this is an important step because whatever we do, we still need organs. And the need for organs is much more than the organs available. And we have to get other avenues. And one of these avenues will be stem cell. Stem cell research, stem cell organs, or stem cell tissues should be used extensively. I think that within the 10 years, following 10 years, they will be used extensively. They will not replace organ transplantation, but they will support organ transplantation. I think we have to use every means that we have because there are a lot of patients that cannot get organs. Wassalamu alaikum wa rahmatullahi wa barakatuh.
Thank you very much. Let's hope for that now the floor is open for the question.
Regarding the countries, regarding the gift given to the relatives if they
Yes.
Thank you very much, Dr. Bar, for this excellent review of the last 20 years fatwas. And we are facing problems in our countries now, in the GCC countries, with giving gifts or support to the family who agree to consent on their organs. Some countries will accept something, some people will say no. So what is your review on this subject?
Thank you very much for this question. First of all, it was discussed with the international Islamic jurist, and it was also discussed with the local jurists here in Saudi Arabia. And both of them have, all of them actually, have agreed that giving incentives is not tantamount to forcing a person, and the person still can refuse. And the incentives are not coming with the point of commercialism. It is an incentive coming from the government, and it is a fixed amount. Usually they don't know exactly what is going to happen. They know that they will be having some incentive by the government. They get a recognition, they get a medal, and they get a letter from in the name of the king himself, and they get some money, yes. But they have agreed that incentives are allowed for this. So there is no compulsion at all. There's no compulsion at all. And it should be, of course, if it is a living donor, he should. They were limiting it to relatives, and they are extending the relatives now a little bit. No, both of them. Yeah, both.
Our administrative coordinator said that we should not talk about money.
Like, usually they don't. They have heard about there is some incentive, but they don't know any of the details.
Yes, you have no idea.
Assalamu alaikum. Shukran, Dr. Bar. I have a question regarding DNR policy for the antenatal diagnosis cases and the postnatal definitive diagnosis with muscular diseases, that when you will put him on ventilator will stay for long and never will be. I'm asking about the consent of the family, because all the family are refusing for DNR because they are saying the baby is healthy now.
Actually, thank you very much for this. Antenatal might be difficult unless you get the genetic type of the disease that you have, and then you get 100% or 90% sure that it is one of the lethal ones or the serious ones. And if you get that before 120 days, That's the upper limit. 120 days is the time when there is installment. That's the sayings of the Prophet Muhammad sallallahu alaihi wasallam, saying after 120 days, the baby or the fetus will acquire the soul. But prior to that, he will not have the human soul. He's living. There is no doubt that he is living. But if there is a very serious congenital anomaly, in 1990 in Makkah al-Mukarramah, Islamic Jurist Council have agreed if the gynecologists and the 3 physicians there have agreed that there's a serious congenital anomaly that is incompatible with life or having a very serious disease, then it is allowed to abort. So this is antenatal, before delivery. And they have allowed termination of pregnancy prior to 120 days, and that will be 120 days plus the last menstrual period. If it is counted from last menstrual period, it will be 134 days, which is quite good time to diagnose any problem if there is a follow-up of pregnancy. Now, after postnatal, now if the fatwa is very aggressive actually on this, and the fatwa from Sheikh bin Baz rahmatullah alayh and his council, they have agreed, if 3 consultants agreed to stop the ventilator, then that is final. The Ministry of Health here has not adopted that fatwa as yet. They have to discuss it, to see it, and to either agree or refuse. We are still in the dark. The Ministry of Health kept the doctors in the dark. Now, it will be very difficult for a physician or 3 physicians with the fatwa to agree to stop the ventilator for these cases. And then they'll be faced with another problem when they raise the problems to the ministry and to the media. And then you get the whole uproar in the media. Doctors are already there. Everybody is saying doctors are killing patients. So you'll get uproar. And that's why I think it will be a very difficult situation. Though the fatwa is with our side, we need the support of the Ministry of Health. Otherwise, the doctors will be in danger. Yeah. Yeah.
Thank you very much for this great lecture. Just a question related to DNR. I think you discussed about the concept of futility when the medical teams feel that it's futile to, for example, if a patient has a metastatic cancer,
yes,
to pursue full treatment, yet on the other spectrum of a hopeless case, when the legal system considers it like an euthanasia. My question is, do you feel that with the fatwa and with family on board, does that provide protection? What if other members of the family, suppose in cases of metastatic cancer, patient doesn't want, the patient is on board, doesn't want full resuscitation, the family is on board, and you have the fatwa, but still, does this open the door if the Ministry of Health legally doesn't support it in the future litigation?
Right. Thank you also. This is another vexing question for doctors every day that we meet. I think there are 2 points here. One point, I'm working in a hospital also, and whenever I produce the fatwas with explanation, I never had any difficulty in taking the agreement of the family. But it might come sometime. But once you get the fatwas with our relatives here, the relatives of the patient, they usually have a great respect for Sheikh bin Baz, rahmatullah alayh. And once they get the fatwas, they get accommodated to it, and then we go to discuss, and then they finally agree. If the next of kin, we don't have this specific next of kin here, but the elder of the family agrees to it, then I think also the rest of the family will agree. And that needs a little bit of diplomacy by the physicians or somebody who's concerned about this question, if they have an ethicist there in the hospital or something of that sort, he can solve the problem easily, I think, with that. Ministry of Health could definitely help if they get their regulation quite clear. That's very important. If we get the support of the Ministry of Health, then the doctors can easily go on with these things. But I think the problem is still there, even in the West.
Just a follow-up, a quick one. Some hospitals have access to an ethicist who says, yes, we believe it's ethical, but at the same time, the hospital would have an access to a legal advisor who says, legally, we are not covered. So I think this dilemma...
I think if you get the fatwas with it, and you go directly to the patients with the fatwa itself there in Arabic, and read it to them, I think you will be successful. I'm sure. I never had any difficulty with these questions at all. I never had. Once you get the fatwa with you.
Thank you, Dr. Ahmad. My question is about the date and time of the death. We are recording the death of the donor when we do the cross clamp. And I know it doesn't happen everywhere in the world. So is it legal or ethically?
Can you repeat the question, please?
Okay. Huh? Retrieval time, yeah. Is it legal, ethically, or because patient is declared death once his brain is dead outside?
Declared brain
death, yeah.
But
when we do this harvesting, we are writing the date and time of death. It's the cross clamp time. So it's like
No, it shouldn't be.
this is what's happening.
No, practically speaking, if the time of the second test happening is done, not the time of his death. If you do it at the time of retrieval, that means he died on the table of the OR.
Okay.
There's controversy, but let us discuss it one by one. Let us talk
I think,
Dr. Qayoum can share us in the...
yeah.
Is there any anesthesiologist here? So, practically speaking, have you had any case in your hospital? When do you write with this thing?
I didn't place successful on that.
Okay. Yeah.
Yes, sir.
In the ICU, we have great evidence documented. Packet test was done, but he's still not taking coordination for any reason. We declare him dead when the heart stops.
You mean to say that in the house?
Or
Practically,
in ICU.
that means ICU. On the OR, doctors, they will never sign a test form. Otherwise, they said that he died there.
I'm not talking about a patient who donated.
Well, we have this problem in the West too. That's really a difficult question. And it's also, it comes to other questions too. It's when the team in the ICU is treating this donor and we tell them the patient is dead. So it's hard to say now we made the brain declaration, now he's dead or before that. And it's hard for them also to work on a dead body. So the solution that most centers have adopted is that when the donor leaves the ICU, we say, okay, now he's dead.
Leave the ICU?
So when he leaves the ICU to the OR.
Our experience in Bahrain, we did a lot of transplants and with the support of the Saudi organ transplant, and they come to take the livers, and we declare the death of the deceased on the ICU. And when they sign, 2-3 doctors sign that he is dead, we give the certificate of death to. After that, the deceased will go to the theater and they give organs, and after this, we resutured everything and we give the disease to the families when they agreed. But it is on the ICU after 3 signatures, put on the certificate, the problem is finished and we declare the brain dead.
Dr. Qayoum?
Yeah.
Okay, I think that it's a controversial area, and I will say what the source of controversy here. The patient technically is declared dead when the testing for brain death is finished. However, there is difference between medical determination and legal determination. And the fatwa stated that for legal determination that the time is counted when the heart stopped. That is for inheritance, for idda, for the rest of usual post-mortem rights. So that area remained vague, that still I think it is a sort of falling back on cardiac death in order to determine the legal timing of death. However, from technical standpoint, it should be by the time that the forms have been signed, that all the testing have been finished, that this patient is dead. Otherwise, you cannot harvest the organs. Sure. I think as a middle of the way type of thing, that once he leaves the ICU, he's considered dead. I think it's a good compromise.
Thank you. We are particularly facing this in Scotland. When we go for operation for harvesting, the OR people they refuse to sign it. So that is the best way.
Right.
That is the time when he leaves the ICU should be signed, because OR people they have never declared the death. They did not check the precondition and the condition and the apnea. They have not done the apnea. They have not done any test. Why should they sign a death?
It doesn't happen in our hospital. The ICU team will never sign the contract. We do it in OR. It's like you do the cross clamp, okay, and we file it.
To take it as a policy of each hospital in National Guard is different, in Ministry of Health is different, in RKH is different. So, yes.
Sorry, let me to ask our colleague. What you are talking about a patient that going to be harvested, right? Okay, suppose you have a brain death patient and brain dead patient, and the family didn't agree about organ donation, about harvesting. In this situation, what time you will declare the death, and who will declare the death? You said ICU doctors never declaring the death.
No, if the patient is a donor and is going to OR, they will not declare death if the patient is dead in ICU.
And if he is not a donor?
If he's not, I don't know. But
He's not a donor. He's just a patient with a brain death and stayed on the ventilator around 10 days, 1 week. Who will declare death that time? He's not a donor.
Only when it's
If he go one by one. If he is not a donor, so would you wait for the people upstairs to come and sign it?
No.
So you will sign it. So it is the same. You sign it if he goes up or he is still down. When? When after the second test in the apnea, when we talk about the after stopping of the heart, that means he's still alive. When the heart stops, even the heart is pumping, is working by the ventilator. He's still there. You do not sign this. So we need another fatwa. We need another declaration of fatwa. It said to be we will continue discussing it for the whole day. We will go back for the same question when we talk about the diagnosis of the brain death with Dr. Qayoum. I think let us we need
just summarize.
Yes.
Summarize the
yes,
point. I think
yes,
there are two fatwas on the religious aspect here. One fatwa from Amman, which I said on 1986, October 1986, which clearly said it is death. If you diagnose brain death, this is death. And then you can sign for the death for that patient. Now, we have other fatwas in Saudi Arabia. They have agreed to stop the ventilator, but you cannot declare the death from the, as Dr. Qayoum has said, from the legal aspect unless the heart stops finally. So the amalgam that has come to as from this difficult question, because there are two different opinions here. The we have two different fatwas. One of the fatwas says brain death is equal to death, to cardiac standstill and respiratory standstill, and that's the end of it. That's it. That's clear. And this is from international Islamic jurists, in which Saudi Arabia was represented. Were represented, actually, the head of the meetings, everybody were represented in Saudi Arabia. But not all of them agreed. It came with the majority of votes. So they still, when they go to their countries, they have their opinions on it. Here they said, okay, we agreed, actually before that fatwa, in 1983 they agreed to stop the ventilator. Once you diagnose brain death, they agreed to stop the ventilator. But he will not be legally, officially dead unless there is cardiac standstill, the heart stops and respiration stops. So if the question is not of importance, if there is no point of taking organs, if the relatives have refused, then there is no hurry. Then you can wait until the heart stops, and then you give them the certificate. Or you write it there. But the problem comes here if there is something that there will be organ donation. You cannot take organs, vital organs, from a person who's still living, if the heart's still pumping. And that's why you have to write it. If there is a question of organ transplantation, you have to write it that the brain has completely stopped, the functions so and so and so on we have done, and the person is dead. That's for the purpose of taking organs. This is an amalgam between two a little bit different views. They agree on so many points, but they still differ on these issues. I think it is important to get accommodated until we get a clear-cut policy from the Ministry of Health. Then we can have a clear-cut policy that's saying that brain death is death.
Neurophysician from King Faisal, Dr. Mohammed Zair Al-Qawi, is going to talk about the brain death diagnosis, or we would rather prefer the word death determination by the brain function criteria. It's better than diagnose the brain death. Welcome, Dr. Mohammed Zair.
Thank you. Once we get the technical part.
Technically.
Okay. Thank you. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I'm a neurologist, and neurologists are not involved in transplantation yet. Maybe in 10 years, if we transplant brains, then I'll be involved in transplantation. My involvement is limited to the diagnosis of brain death, which I don't like the term, because what we are doing, it is not brain death. It is not an organ death. It is death determination by brain function criteria, which is the most accurate description, although it is more cumbersome and lengthy phrase. It used to be easy before 1960, I would say, before 50 years ago, when a catastrophic event would happen to a patient and the patient's heart would stop, and then the physician comes and finds no pulse, and then he pronounces him dead. After 1950s and 60s, there was a great improvement in resuscitation techniques. And many of those patients who had a cardiac arrest or any or accident or any acute event, they were resuscitated and they became, they returned to life, or they were maintained in a living condition. However, a good number of them would become ventilator dependent, and those who are ventilator dependent, they have an outcome either to become independent of respirator and become alive, or they remain ventilator dependent and then become in a persistent vegetative state, or they should be pronounced dead, which necessitated the idea of having another way of diagnosing that this person is not coming back to life, which was the concept of brain death. So what happened is that there was a shift from determining death by stoppage of the heart beating to the arrest of the brain function. And as a matter of fact, I would argue that this is less definite than this, simply because right now the heart is stopped on a daily basis in the operating rooms for the cardiac surgeons to operate on the heart, and then they shock the heart back into beating. So during this time that the heart stopped beating, was the patient dead, and was he revived? Number two, even when we used to call to wait for the heart to stop, physicians used to wait for 5-10 minutes before they pronounced the person dead. As a matter of fact, what they were doing, they were waiting for the circulatory arrest to affect the brain and to get no function from the brain without knowing that this was what they were doing. So I think that one can definitely say that this is more definitive of no return to life than this one. So the two basic questions when we are confronted with is if the essence of life resides throughout the organs, or is it in a special organ of the body? And how can we avoid inaccurate determination that this person is not coming back to life? So this raised many almost philosophical questions. What is the definition of life? If we are trying to define death, we have to define life. Is it cellular life? There is living functions in every cell within the body. The billions of cells that we have, they have functions like breathing, like nutrition, like excretion, and so on. However, if we take a cell and we put it in a dish and grow it, and the person from whom that cell was taken out, he dies, and the cell is still alive, do we say that these cells, there are many commercial cells that are sold by companies, many clones of cells that are sold to research centers and so on, from the persons from whom these cells were taken have long been dead, and yet their cells are being sold. So cellular life per se does not define life. Cells come together into organs. So is the life of an organ defines the life of a person? And to clarify this question, we look at a person with a end-stage renal disease who receives a kidney from his brother, a related donor, who gives his kidney to his sick brother. Then the donor may die from a different cause, like get involved in an accident or something. Do we say that, no, he hasn't been dead yet because there is a kidney of his that is functioning in his brother's body? Nobody says that life of an organ means living. So organs come together and work together. However, if there is a brain that is not functioning well, that this person, let's say a person had a circulatory arrest and he had severe brain dysfunction, but he is able to breathe on his own, he is able to maintain the function of all of his organs, the digestive organ, the circulatory organ, the respiratory, and so on. They are functioning, but yet there is complete absence of interaction with his surrounding. Do we say that he is living since all of his organs are, where do we draw the line? And then on the top of that, we have a person with his full functional capacity. Nobody says that a person with persistent vegetative state is dead. Persistent vegetative state is completely different than brain death, and we'll see why it is a source of confusion and it shouldn't be. So that's where we draw the line. It's not organs life, it's not cellular life, it is the functioning of all of these organs, even if there is no complete cognitive function that will join these organs together. So there are several ways of looking at death. There is the metaphysical concept that this person have left from this life to another life. There is the legal definition, the time of death after which the person's inheritance is divided, the person's wife doesn't no longer belongs to him, and so on. So there are several legal consequences for determining death, and this is one of the problems that we raised in the previous lecture. And there is the more technical clinical criteria that physicians should be using in determining death. So that led us to search what is the essential criterion for death. If you ask many people down the street, and they would say it's departure of soul. Well and good, but how do you measure departure of soul from the body? There is no tangible measure that you can say, okay, the soul has departed. And there is another problem with this definition that I'm going to raise, even from religious standpoint. If we have to be more accurate, we say that it is the point of no return to life. When we determine that this person it's impossible for him to return to life, then we can say that he is dead. The problem with the first definition, as I mentioned, if we go back to the Holy Quran, we say that in Surah Al-Zumar, Allah يتوفى الأنفس حين موتها والتي لم تمت في منامها. So there are two states in which the soul departs the body, and it may depart the body at the time of death or temporarily when the person is asleep. فيمسك التي قضى عليها الموت ويرسل الأخرى إلى أجل مسمى. So the souls that for which death had been ordained will be retained outside the body, and the ones that their time has not come, they will be returned to their bodies. So the legal definition of death before 1968 was the irreversible cessation of cardiac and pulmonary function, and this is a time-honored definition that had been probably considered for decades because there was no way to treat cardiac or cardiopulmonary arrest. From 1968 and on, there was the concept of irreversible coma, and in 1981 in the United States, there was the Uniform Determination of Death Act. The law was passed that death can be determined by either cardiopulmonary death, the old-fashioned type of determination, or by the so-called brain death. There were fatwas that Dr. Albar has mentioned about brain death and about transplantation, even as long back as 1978 and 1982. The Harvard first the medical school criteria, which were the first brain death criteria, has almost all been retained in one form or another. So how do we apply these criteria into clinical situation? Before we go to that, we should think a little bit about the normal anatomy of the brain. We know that the brain is roughly divided into cerebral cortex and into brainstem, and the brainstem houses a very, very important part for life and for consciousness, which is called the reticular activating system. The cerebral cortex serves for cognition, voluntary movements, sensation. The brainstem has three parts. The midbrain has cranial nerves 3, which is for pupillary function and eye movement. The pons has the cranial nerve 4, 5, and 6, and serves for conjugate eye movements and for corneal reflex. And the medulla serves for the cranial nerves 9 and 10 for pharyngeal reflex and tracheal reflex, and for respiration, which is the most this working? Okay, which is the most important function for maintaining life. However, reticular activating system is a loose connection of many gray matter that are dispersed around the fourth ventricle and the aqueduct, and it mediates wakefulness, and it just receives input from the periphery and sends stimulating output to all the cerebral cortex and serves all the functions. This is the place in the nervous system where the smallest lesion can have the most devastating results. If one is asked which is the area of the brain that you can put the smallest lesion and cause the most devastating neurological okay, thank you. It would be around the aqueduct.
I told you to on this one. Why you not on this one? This is on, but on from your side. Hello. This is you? Hello. Hello.
And they cannot apply. Two of them cannot be applied.
Hello. Hello.
Two of them cannot be applied at the same time to the same patient.
Hello.
The persistent vegetative state has the person has a normal sleep state size.
Yeah, it's not working. Where's your name?
Wait. I'll come. Just a minute.
Hello.
And this is usually caused by a diffuse brain injury with preservation of a brain stem function. So the vegetative state is described as eyes open unconsciousness. There is a dissociation between being awake and being aware. The person gives you the impression that he's awake, but he's not aware of his surrounding. And the upper parts of the brain do not receive adequate stimulation from the lower part, which is the brainstem. Many of the cases that went to the media and they were thought that they were brain dead and they were awake after 10 years and so on, all of these were vegetative state. You are aware of the names of the Karen Quinlan, Nancy Cruzon, and Terry Schiavo. Vegetative state has a different outcome depending on its cause. If it is post-traumatic, it has a good cause, and if the person is vegetative after 6 months, he still has a chance of being conscious after about 20% after 1 year. If it is non-traumatic, like what happened, vegetative state after a cardiac arrest or a septic shock or whatever, there's only 1% chance for this person to become conscious. If we examine him after 6 months and he is still in a vegetative state, that means that he has 1% or less chance of regaining consciousness by the end of the year. Locked-in syndrome is very important because it's different than vegetative state. It is usually caused by a lesion in the ventral part of the pons. Ventral part of the pons takes all the descending tracts, that takes all the orders from the brain to the pharyngeal muscles, the larynx, and the movement of the upper and lower extremities. So the person will be not able to speak and not able to move. These are the two characteristics that we judge if the person is awake or not. If he moves or if he speaks. If he loses both, we may erroneously label him as unconscious. However, because of complete paralysis and preserved consciousness, one has to be careful that this person is conscious. How can we prove that he is conscious? There are preserved eye movements. Only vertical eye movement will be preserved because horizontal eye movements are served at the pontine level, while vertical are served by the midbrain level. So if this is a lesion at the pontine level, at the pons, then vertical eye movements will be available, and one can communicate by looking down or looking up. And as a matter of fact, a person by the name of Jean-Dominique Bobby, he was the editor of the French magazine Elle. It's a feminine magazine. He was born in 1952 and he died in 1997. But 2 years before he died, he became in a locked-in state. And during that time, he was able to author a small book. He called it The Diving Bell and the Butterfly, a memoir of life in death. And what he did, his wife brought a communication board and she would pass her finger over the letters. And the letters were organized by the frequency of their occurrence in the French language. So when she reaches a letter that he wants, he blinks. So she collects the letter. It's a painstaking chore, but she was able to do it. And he wrote a book, and the book was called was published in French and then translated into English as The Diving Bell. It's a small book, about 90 to 100 pages, but it's very interesting to tell how conscious, aware, cognitively sound person can feel when he is completely cut off of his surrounding. So another mimicker of what people may think that it is a brain death. There are several misconceptions. One of them is what we already know, that since there is a heartbeat, he's alive. Brain dead person have permanently lost capacity to think or to go back to life or to communicate with others. Or he is in coma. Coma implies reversibility. When we bring a patient from the emergency room in coma, we try to treat him. He's in a diabetic coma, he is in other causes for coma, then we treat it and it's reversible. With rehab, he will get better. It's irreversible. Brain dead person cannot go back. And that's why communication with family, one should be very accurate in selecting words. It's incorrect to tell them that he is brain dead. It's better to say that he is dead. Brain dead is what we as physicians followed in order to determine his reversibility or not. But for the family, qualifying the death by brain death means that there is an organ death and it's not a whole person dead. He is on life support equipment. That's wrong. These organs do not support life. He's on mechanical ventilation. They support ventilation only. He will be dead when he's disconnected. No. You disconnect him because he is dead. It's not that he will be dead once we disconnect him from he's kept alive by the machines. No. These organs are supported by the machine which is supplying oxygen. So one has to be very careful in selecting his words when communicating with the family. Otherwise, it will cause unnecessary confusion, misconception, and anxiety. Of course, causes of brain death can be either direct brain involvement or secondary brain involvement. We all know about that. Subarachnoid hemorrhage is one cause. Cerebral hemorrhage is another cause. Head trauma, severe head trauma, meningitis, cerebral anoxia. What happens with all of these things is this downward spiral can be started at any point, either because of neuronal injury or because of increased intracranial pressure or whatever. Each step would lead to the other and would lead to downward spiral. What happens in the final event in all of these is that the intracranial pressure exceeds the mean arterial pressure. The mean arterial pressure minus intracranial pressure is what supplies the blood inside the brain. If mean arterial pressure is less than the intracranial pressure, that means that the circulation is shut off and it is incompatible with life. So all of this cycle happens from any cause, but it leads to the final common pathway of lack of circulation to the brain. In trying to diagnose brain death, we have to rely on, first of all, essential preconditions. We cannot jump the steps. We have to start with essential preconditions, then find the necessary exclusions, then we can do the test. One cannot jump to the tests right away because it may be fraught with errors. What are the preconditions? The event that led to the current situation must have passed over 6 hours ago. And the first 6 hours are devoted to resuscitating the patient, finding the cause, and so on. There should be a positive diagnosis of a condition that usually leads to brain death. We should know why this person is in this condition. He had a massive subarachnoid hemorrhage. He had a severe head trauma in a car accident. He had meningitis for a few days, and then finally he herniated, and so on. The person must be comatose, unable to breathe, and he's on ventilator, showing no respiratory efforts. If these preconditions are met, we go to exclusions. The person should not be hypothermic, because hypothermia may mimic brain death, and it is reversible. Should not be in a metabolic or endocrine abnormality, like in a severe hypoglycemia. He should not be in an untreated cardiovascular shock. If there is a shock, he should be treated. And sedative drugs should be ruled out. Then, if we pass through one step, two step, then we come to the third step, which is testing in suspected total brain failure. And the testing should include test of the brain stem function, test of the cerebral function, and test of the respiratory function. Cerebral function, brainstem function is easily tested, as I'm going to mention. Cerebral function has a little bit of problems, but we're going to discuss it. And then respiratory function refers to the lower part of the medulla, where the respiratory center is. So what happens in a normal brain is that we can see the diencephalic structures above this line, which is the tentorial notch line. And in a person who is brain dead, like this one with metastatic melanoma, we see that the diencephalic structures have passed through the tentorial line and went down, which is the herniation. And along with that, because of the downward displacement of the brainstem, we get what we call Duré hemorrhages, as described by a French pathologist, Duré, because of the stretching that is applied on the anchored basilar artery, which supplies the blood by penetrating artery to the pons. When these are stretched, they cause hemorrhages. So brainstem functions are tested by reflexes, and there are several reflexes that span all the extent of the brainstem, from midbrain to pons to medulla. Pupillary reflex, normal pupil shows constriction to light. We know that from our student time. If we shine a light and the pupil is large and it is not okay, it's enlarged and it is not reactive to light, then the person lost that reflex. And the pupillary reflex, as I mentioned, it's concentrated in the upper part of the midbrain near the aqueduct, and it is within the vicinity of the same reticular activating system. Facial sensation and motor response, we check for corneal reflex, and the we check for jaw reflex, and for grimacing for supraorbital or temporomandibular joint pressure. Oculocephalic reflex, which is commonly known as doll's eye movement, instead of being confused by all of this wiring diagram, we can remember a very simple rule that if we move the head in one direction, by inertia, the liquid in the semicircular canals will move in the opposite direction, because we move the head this way, the fluid will, relatively speaking, move in the opposite direction, because the container, which is the semicircular canal, moved that way, and the inertia of the fluid allowed it to move relatively to the opposite direction. Usually, the eyes would move in the same direction that the semicircular canal fluid had moved. So when we move the eyes in this when we move the head in this direction, the eyes will move in the opposite direction. That's if this complicated reflex center is working. If it is not working, there is no movement of the eyes. So that's basically what is the doll's eye movement. So we move the head to the right and to the left. If the eyes do not move in the opposite direction, then the oculocephalic response is positive, or there is no reflex. The oculovestibular response, to understand it, we look at the anatomy of the vestibular organ, the lateral semicircular canal. The lateral semicircular canal projects on the medial wall of the middle ear. There are only a couple of millimeters that separates it from the tympanic membrane. If we bring ice water and put it in close vicinity to the tympanic membrane, we cool off this area. When we cool off this area, the fluid inside this becomes heavier, and then it will go down. And then it will be replaced by a warmer fluid that will be cooled off, and it will go down. So basically what we are doing with injecting ice water is to create a current that will be going downwards. So how do we do that? We check for tympanic perforation, we check for occlusion of the canal by earwax, and then we instill 50 cc's of 0 centigrade cold water over 2 minutes. And the patient, if he is conscious, he would not tolerate even 0.5 cc. He will be very vertiginous, he will have nausea and vomiting, and he will have nystagmus that usually referred to by the mnemonic cows, which is cold, opposite, warm, same. The reason we call that, because conventionally we call nystagmus by the more observable direction of movement, which is the fast phase. But the fast phase is a compensatory phase that's generated by the brain. That's why it can be only generated in a person who is awake, where his cortex is functioning. What we are interested in is the stem function, which generates the slower movement, and the slower movements will be in the same direction as the fluid, which means that when we inject cold water, the eyes should deviate the same if the reflex in the brainstem is functioning. If there is no response, there is damage. Again, we generated by ice cold water, we generated a current that goes down, then the eyes, we expect it to go down. If there is no function in the midbrain, then there is no reflex, and then we conclude that there is damage there. So this is what happens in a patient who is comatose, but he has preserved brainstem function. This is what happens with a patient who is comatose, but he has no brainstem function. The eyes remain central and do not move. So in summary, brainstem testing, we can test for corneal reflex, we can test for grimacing by pressure on the temporomandibular joint, we can test for pupillary reaction, we can test for doll's eye movements, we can test for calorics, and all of these together tells us that the brainstem is not functioning. Then we go to cerebral function. Well, we know that the function of the brain, of the cortex have gone because the patient is comatose. So we go to surrogate measures to tell us if there is any residual function of the brain. We either go for electrical measure by EEG, or we look for blood flow to the brain by angiography or radioisotope or by transcranial Doppler. So these are what we call as confirmatory tests. This is a normal electroencephalogram, and this is how the electroencephalogram look like in a electrocerebral silence. There is a major difference between this recording and this recording. This recording is recorded at a sensitivity of each 70 microvolts will move the pen 1 millimeter. This one, each 2 microvolts will move 1 millimeter, which means that this one is about 35 times more sensitive than this one. That's why we can see that it picks up the electrocardiogram as it is conducted by volume conduction from the heart to the head. So these are the artifact of electrocardiogram, but the rest of it is just a noise, machine noise, and there is no cerebral activity. Advantages is that the EEG is portable, safe, and non-invasive. It is proven to predict non-survival. It is susceptible to artifact, especially in ICU, where it is a very electronically hostile environment. False positive presence of EEG findings in patients with, who shortly had the brain autolysis relate to misinterpretation by an inexperienced person. EEG demonstrates cortical activity, and isoelectric EEG in the absence of sedation says that there is no electrical activity. However, if there was sedation, if there is intoxication by barbiturate or so on, we can get similar lack of activity. Blood flow studies, absence of blood flow to the brain or any other organ is incompatible to life. Why the mechanism of absent perfusion? It's either the cycle that I mentioned, the massive increase of the intracranial pressure, or alternatively, that the vascular endothelium with hypoxia swells up and then it causes shut off of the circulation and what we call a no reflow phenomenon. To test for cerebral circulation by angiography, it's inconvenient. However, we may stumble over that by a person we take immediately to angiographic suite because we suspected that there was a subarachnoid hemorrhage, bleeding aneurysm, and so on. We try to inject and there is no flow to the brain. Then we have our answer. Or we can do the radionuclide flow study by giving intravenous technetium and trying to see where it reaches. Okay. Or absent blood flow have correlated with clinically non-survival. So this is the normal cerebral angiogram, and this is what happens when we do cerebral angiogram in a brain dead. It stops at the base of the brain and there is no blood flow inside the brain like we have here. There is extracranial blood flow in the meningeal artery. Technetium will show that there is activity in the face, activity in the temporalis muscle, but there is no activity inside the brain. Transcranial Doppler ultrasonography, we insunate the arteries at the base of the skull by external transducer, and we can find in a normal situation pulsating artery like that, or flowing, or blood flowing inside. This is sequential recording that happened in a patient while he was herniating. What we can see is that increase in the systolic and decrease in the diastolic flow. There is no diastolic flow. Look how much diastolic flow there was, and the diastolic flow is decreased because of the raised intracranial pressure, and then even the systolic flow becomes less, and then it turns into what we call a to and fro phenomenon, which means that the red cells are shaking back and forth with each pulse, but they are not reaching anywhere. And then we have only some pulsation with systolic flow. Apnea testing, the idea is to challenge the respiratory center with high PCO2 and to protect the brain and to observe for any movement. So what we do is to pre-ventilate with 100% oxygen without changing the setting of the ventilator, because we don't want the patient to blow off carbon dioxide. Then we disconnect the ventilator and we supply oxygen by intratracheal catheter, and then we observe for any respiratory movement for about 10 minutes, and we look for the changes in the arterial blood gases if the PCO2 have risen above 60 millimeters of mercury, while monitoring the patient's heart rate, arterial blood pressure, saturation of oxygen, and respiratory movement. The determination in children, not very much different than adults, except that it requires 2 separate examinations, and the 2 separate examinations have a longer period of time as the child becomes younger because of the resilience of the CNS in newborn children. I'm going to quickly talk about the pitfalls. The most important is that the preconditions are not met. If there was no waiting for the initial insult, if there is no obvious cause for the coma, if there is some respiratory movement, and from time to time, the media catches on some cases where physicians have failed to follow the steps accurately. In March '82, this person had a motorbike accident, and then he was pronounced dead after 4 hours of the accident. They did not wait for the preconditioned 6 hours, and then he was home after 24 hours. So they caught on it, and they said that there is inaccurate determination of death. All the exclusions are not exhausted, like the patient may be hypothermic or may be hypoglycemic or may have taken an extra dose of barbiturates or benzodiazepines. Or we say that the pupils are dilated, so there is no function, but he had received atropine in his eyes. Or there is no motor response and no ocular movements, but the person had received atracurium or some kind of intoxication with organophosphate. Or there is no reflex eye movements, but the stimulus did not reach the tympanic membrane because the canal was occluded by wax. Apnea testing, if we did not wait for adequate rise in CO2 or we did not observe, we put the patient and then we got busy with the next bed. This is the last slide that I'm going to show. How strict the criteria that are applied in the kingdom, and I think in the other Gulf countries. This was a study that was published by Wydick from Mayo Clinic in the New England Journal of Medicine about 10 years ago. Time between 2 examinations from 6 to 72 hours. We follow that at the kingdom. Exclusion criteria are required in all 77 countries. Apnea test is required only in 41 out of 77 countries, and it is required at the kingdom. Confirmatory test is required by only 26 countries. It is required in the kingdom. Written laws are available in 67 countries. We have guidelines. We have a special form to be filled out. One physician is acceptable in 32 countries. In the kingdom, we require 2 physicians to sign the death determination, which is the requirement in 33 countries. So in looking at all of these criteria, the kingdom has a very strict rules for determination of brain death to prevent any erroneous determination. Thank you. No, that's part of your examination.
Do you need consent to take the blood or to take angio or chest X-ray?
You don't.
This is part of the test.
Okay, that's intervention. What you are doing testing, not intervention. But if you need to put a stethoscope on the patient and listen to his heart, you don't need consent for that. This is similar to if you need to check his blood pressure. That's testing.
Sometimes if we want to shave do the EEG and to shave the female, we need the consent.
We don't usually shave.
It happens to you certainly, yes, I know. It could be. Any other question? Doctor from Kuwait, where's our friend? Waiting for a question. Any question? Do you want to ask the same? Okay. Yes.
Yeah, my question regarding, hi everybody. My question regarding the previous lecture when I was talking about the declaration of brain death. In Kuwait, usually what's happened is the one who's signing the consent or signing the certificate of death is the treating doctor. And not before we're sending the patient to the OR or when the heart stop is the actual time when we're signing the consent. And I believe that while we are here in this conference, the council of this conference should be declaring these things. So it will be for all the GCC countries. This is the best things. And sending to the executive office of the Minister of Health of the GCC. This is the proper things. I can see here in Saudi Arabia there is a conflict in this subject. So it should be clarified. Thank you very much.
We have to pass it as a recommendation of the conference. And as Dr. Bar said, that we'll give it to Minister of Health, and it will be part of the policy and part of the recommendation to be out in this conference. And as you said, that is one of the good things in these such conferences. Regarding the same.
Direct to Dr. Al-Bar. If we have a case diagnosed as a brain death in Hospital A, an example, and we transfer the case from Hospital A to Hospital B for harvesting, according to the facility. Okay. After that, yes. Who is going to make the death certificate? Is it the Hospital A or Hospital B? And actually, doctor, we have this case in reality, by the way.
Where was he diagnosed?
He diagnosed in Hospital A.
A. And practically speaking, we don't transfer the patient unless or until he's fully documented to the another patient for
patient
harvesting.
Being fully documented, transferred to Hospital B for harvesting because of the facility.
The same when you're taking from your own hospital to the OR. It is from the A hospital.
No, different. It's one building, but
okay.
A to B.
It is the.
It's very important, really, because we face a lot of cases like that.
Yes, we did face. So the Hospital A should.
Hospital A. Okay, when you contact Hospital A, they said, no, the case has been transferred to you, you issue the certificate. It's a big company.
Okay, then. If he was arrested between Hospital A and B, who is going to sign the traffic line? Who is going to sign
No, doctor, because we're facing this one. If we
yes,
don't
I agree with you.
If we don't have procedure or any steps to be done for it, we will be in very bad situation as a coordinator.
Dr. Bashir, do you want to comment on that?
Yes, this is very important point. We have to differentiate between two issues. To issue the brain death declaration and the death certificate. Here, at the legal point of view, the death certificate should be done before the harvesting. So where the harvesting took place, the death certificate will be issued. Usually it's the ICU of the harvesting place or in the OR. But the brain death certificate will done where the brain death was declared.
No, but here, Dr. Saleh, I tell you something. in our hospitals in Saudi Arabia. If you transfer a case from hospital A to hospital B, and you back to hospital A for the certificates, he said, no, sorry, it's not my responsible. Huh? Hospital B?
Yes, the death certificate. No. We are really confusing people here. Because Dr. Bishop, before you come, we had a discussion, a lot of discussion about that.
Sorry?
It was shifting for, I think...
shifting for harvesting.
May I make more clear, because Dr. Qawi, he gave a very nice statement when he commented on that.
Yes.
Would you please repeat what you said about that?
Well, I think that it is a source of confusion, because we need to, it is a matter of timing. When, what minute, what hour, what day this person died. Because that is important for courts to decide about his inheritance and all of the other things. However, from medical standpoint, as soon as you have completed the 2 examinations, the confirmatory test and so on, you can sign that the brain death certificate that he is declared dead. In that case, to issue the death certificate and to put a time and date on it, unfortunately, there are 2 conflicting, as I mentioned, 2 conflicting fatwa. The fatwa from مجمع الفقه في الأردن, which was a long time ago in 1982. It accepted that the time of death is the time of the certificate, the testing. However, the fatwa from the kingdom that determined the time at the time of heart stopping, which means that this confusion is not going to resolve from medical standpoint, because it's clear from medical standpoint. It is a procedural thing which requires a certain laws or guidelines to be passed by the Ministry of Health.
As I said in the morning, that if we keep discussing this, we will not end.
There's a lot of points.
Yes. And before you send it to hospital B, call me and tell you who's going to sign.
Your phone always off, Dr. Qayoum. I'm sorry.
And I say thank you. Any more last question? Any? The female side, the nurses, do you want to ask any question? Anybody want to? Okay. Thank you very much, Dr.
Thank you.
Thank you very much.
Hello.
We slight change that evaluation. Speaking guest is going to be Dr. Francis. He's a professor, Professor Francis, a professor. Sorry. Robert, sorry, I'm sorry. There is some change in papers. Okay, I'm sorry. Sorry for confusion, and Welcome, Dr. Robert Fitzgerald. Dr. Robert is the chairman of the Carol Landsteiner Research Institute, and he is an anesthesiologist and intensive care medicine. He's the director of abdominal surgery and anesthesia of Department of Anesthesia and Intensive Care Medicine in the city of Vienna Hospital. So welcome, Dr. Fitzgerald. He's going to talk about the maintenance of the brain death. So you have already diagnosed the case, well diagnosed. Do you need somebody to take care of the patient before you sign, or before you go and harvest? Okay, yes. Time?
Okay. Does this work?
Yes.
Okay. Thank you for the invitation. I'm very honored to speak here.
You're on the...
So. Yeah, now we managed all the technical difficulties. Thank you for your patience. Organ. So your donor now is declared brain deaf. And now something starts what nobody really wants to do. Why I started doing that, it was, they said, oh, he's the youngest in the team. He can work on that because this patient, he's dead. Nothing can happen. But that's not the right way how to do it, because it is difficult. It is by far from nothing can happen, because you're not treating a patient, you're treating several patients, because the goal is that you should not just get the organs, this donor to the OR, so that these organs can be harvested, but you should take care of all the recipients, because the life and the health of the recipients is going to depend on what you are doing in this period. So the goals are to, in the first line, to achieve optimum donor physiology, and to increase the number of potential donors whose organs are suitable for transplantation, increase the number of organs transplanted per donor, and improve graft function and recipient survival. So that's actually not the thing that the least experienced and youngest team member should do. So, brain death. Brain death is not just there when it's declared. Brain death mostly is there a long time before. Only when the process of the brain death declaration has stopped, finished, then you say he's brain dead. But the deterioration process has started long before. And so actually you're treating the patient before he becomes a donor. And so the switch from treating the patient to treating the donor is not so big, because all these processes that have started already and are working, you have been treating now after all the guidelines you have for patients in your ICU. And you don't have to do anything very much special, but you have to know that processes have been started due to the death of the brain, due to the central regulating organ, that you have to correct in order to keep the situation in a way that the organs are still viable when they are transplanted. These are only some of the disorders that can appear in this situation. Hypertension, diabetes, insipidus, you know them all. I don't have to count them out here. You see the high percentage that of these symptoms, how they occur in donors. And that shows you also that there's hardly a donor that's really stable all the time. Of course, it's also a factor of time. The longer you keep this donor after brain death, the more he's going to deteriorate, and the more of these imbalances will occur. So what you have to do is you have to know the physiology, what's happening, and what is going to go on as you bring this donor then to the situation where organs can be harvested. The problem is we have a poor understanding of the physiology of this situation. There's not a lot of research done. Most studies were animal experiments. Most studies were retrospective studies. We have many, many guidelines, not only national guidelines. There are many centers who have their own guidelines. And so you can imagine that not everybody has the truth, and some must be wrong even.